Hi, I'm Sean Grambart. I'm here at the AANP conference in San Antonio, Texas. I'm the president of the American College of Foot and Ankle Surgeons, and it's my pleasure to talk to you about some of the things that nurse practitioners, PAs, and foot and ankle surgeons can be involved with together. When we're dealing with patients, I think one of the more common patients that we often see is the diabetic patient. Obviously, with those patients, that's a group of doctors, physicians, nurse practitioners, physician assistants that deal with these patients, and it's a team approach to it. One of the big pathologies that we see that can often be misdiagnosed is that patient with Charcot arthropathy, or the patient that presents with that red hot swollen foot that oftentimes will get misdiagnosed with a cellulitis, maybe with a fracture, and they'll be treated differently with antibiotics. It's just not getting better. And that's the time where you have to think outside the box a little bit and look for the Charcot arthropathy type of pathology where the foot starts to break down due to the neuropathy, due to maybe increased blood flow, which gives the red hot swollen foot. That's a common presentation that we all see, and it gets misdiagnosed. That's that patient, if you see that they're not responding to antibiotics over maybe a period of 5 or 6 days, they're still having the red hot and swollen, then you have to start thinking of Charcot arthropathy for the diabetic patient. Other pathology that we often see is obviously fractures. There are certain fractures that may need surgery. There are certain fractures that can be treated conservatively, but often those fractures can be real close together. Example would be a fifth metatarsal fracture. In the area of the fifth metatarsal, especially with the proximal aspect or towards the base, styloid process fractures are something that can be treated conservatively. A walking boot for 6 weeks, make sure the x-rays are progressing, versus a Jones fracture, which is that fracture that it looks like it's okay, but yet it still is one that has a poor tendency to heal by itself, that typically requires surgical intervention for those patients to respond and to get back to activities as quickly as they can. Obviously, we all see pediatric patients, peds fractures, flat foot deformities in kids as well. With flat foot deformities, this is something that 95% of flat feet are just flat feet. They may need custom orthotics if they're having pain. They may not need anything. In 5% of those patients, it can actually get problematic, where at times they actually need surgical intervention. If it's limiting their activities, if they can't do the things that they want to do, that's when surgery can be indicated to actually get those patients back to doing what they're doing with a reconstruction. Geriatric patients is just another subset. We all see bunions, hammer toes. Those are things that can be treated conservatively, once again with shoe wear, but that is something that surgery does help with as well. So for the most part, we all see really similar pathology. We have similar patient groups. I think it's a great working relationship that we have, and that's something that should continue into the future.